Good evening. My name is Sarah Ackerman, and I'm the director of the incredible Center for Digestive Health team at Virginia Mason Franciscan Health. It's my pleasure to welcome you to tonight's lecture. We host a lecture series yearly on a host of topics of digestive concerns. The Center for Digestive Health is comprised of a team of pathologists, gastroenterologists, surgeons, oncologists, endocrinologists, and radiologists who are looking to optimize care of the patient through our culture of quality, focus on access, innovations in research, and educating the next generation of caregivers. By emphasizing innovative quality, patient care research, and education, we provide excellence in our areas of distinction, including the Center for Weight Management featuring bariatric surgery and medical weight loss, our Center for GI Cancer Prevention and the care of esophageal, colon and rectal, liver, pancreas, and biliary diseases, as well as motility disorders. Education and research is truly embedded in everything that we do. Our providers work together to improve your health and well-being, teach the world about what we do best, translate that research into care for you, pursue quality initiatives to provide that very best care for you, and to discover innovations to transform your experience at Virginia Mason Franciscan Health. We've been doing this work for a long time, and since 1982, our national breakthroughs have truly impacted how we treat digestive concerns, and that has been at the regional, national, and international level. And while we feel that the Center for Digestive Health is very special, we have been honored to be awarded numerous accolades over the years, a reflection of our hard work and the providers doing their best to dedicate that work to their patients. Our presenters this evening are Dr. James Lord and Dr. Tim Zisman. Dr. James Lord joined Virginia Mason in 2010. He's a board-certified physician by the American Board of Internal Medicine, and he obtained his medical degree and a PhD in immunology from the University of Washington. Dr. Lord remained at the University of Washington for both residency and a GI fellowship with a physician-scientist track. His passion for immunology led to his appointment as an assistant member in the Translational Research Program at the Benaroya Research Institute at Virginia Mason, where the Lord Laboratory investigates the immune cells of patients with inflammatory bowel disease. Dr. Timothy Zisman joined Virginia Mason in 2019 from the University of Washington. Dr. Zisman completed his medical degree at Virginia Commonwealth University as well as a Master's of Public Health from Harvard. He completed both residency and a GI fellowship at the University of Chicago Medical Center. Dr. Zisman maintains a robust clinical research program focused on both Crohn's disease and ulcerative colitis, creating opportunities for patients to access cutting-edge therapies at Virginia Mason Franciscan Health. We're so honored to have both Dr. Lord and Dr. Zisman speaking this evening, and we look forward to engaging with them in discussion during our Q&A session following their presentations. Thank you.
Hello, I'm Dr. James Lord. I'm a gastroenterologist at Virginia Mason Medical Center in our Inflammatory Bowel Disease Center of Excellence. And today I'm going to be talking about new therapies for inflammatory bowel disease. Let's start by saying where we're coming from. In the last century, there were a handful of types of inflammatory bowel disease medications, predominantly pills, steroids such as prednisone, immunomodulators such as azathioprine, and this class called aminosalicylates, initially sulfasalazine, but joined by mesalamine and valsalazide in the later decade or two of the 20th century. But for the most part, there are fairly limited treatment options, despite Crohn's disease having been described about a century ago. However, in the past 2 decades, this armamentarium of treatment options for inflammatory bowel disease has really markedly expanded. In fact, the first of the biologic drugs, an anti-TNF agent called infliximab, was actually FDA approved right at the very end of the 20th century. And it now has gone off patent, and there are several biosimilars available for it. It is an IV infusion, and so a few years later, adalimumab, certolizumab, and Simponi all came out as self-injected medications for greater convenience. but they were all still anti-TNFs. So for over a decade, the class biologic usually just was synonymous with anti-TNF as a therapeutic. And it wasn't until 2014 that a new class of biologics called anti-integrins, specifically vedolizumab, really became a major point of therapy for inflammatory bowel disease. And in the subsequent years since then, anti-IL-23 as the therapeutic strategy has come out with the advent of ustekinumab, first for Crohn's and then a couple of years ago for ulcerative colitis. And then most recently, there's been a return to oral medications. Now, all of the above are what we call biologics, meaning that they're proteins. You can't eat them. You have to inject or infuse them. But in 2018, the first new oral medication for inflammatory bowel disease was FDA approved for ulcerative colitis, called tofacitinib. It's called a Jakinib, and I'm going to be talking about those. But that less than a year ago, this is actually supposed to say 2021, Ozanimod was FDA approved for ulcerative colitis. And so, as you can see, the past 20 years have shown far more advances in the treatment of IBD than the century beforehand. Now, each of these have their various pros and cons, and I'm not going to dwell much on the pros and cons of the older medications. The consistent con of all the newer medications is that they're generally very expensive. Even the ones that are biosimilars are still very expensive. There may be some risk of infection slightly above background with the anti-TNFs, but it's not as bad as steroids and immunomodulators. But the newer biologics like anti-integrins and anti-IL-23s appear to be really remarkably safe, just not very fast. And then the oral medications, I'm going to go into some of the toxicity on them because really my goal today is not to talk about what currently exists, but what either is coming or has just come out. And that largely fits in these three categories of the anti-IL-23s, the Jakinibs, and the S1P1 agonists. So let's drill down a little bit more on this, starting with the anti-IL-23s. Well, what does this gibberish mean? An anti-IL-23 is a biologic drug, so it shares with the anti-TNFs like infliximab and adalimumab the fact that it's a protein, so you can't eat it. You have to inject it or infuse it, or else it just becomes really expensive food. These are all based on a human antibody, but they're specifically targeting a protein. In this case, it's a protein that is a hormone that immune cells use to talk to each other, and those are called either cytokines or interleukins. So all the interleukins that's short, IL is short for interleukins. So interleukin 23 seems particularly important in inflammatory bowel disease, in part because 20 years ago there was some genetic data to say that people who have an inborn mutation inside the IL-23 receptor that limits its activity, that weakens the IL-23 receptor, they're actually protected from developing inflammatory bowel disease. And there have also been a whole bunch of other mutations near the protein that correlate with a higher or lower incidence of IBD, implicating that this particular receptor pathway is really central to how Crohn's disease and subsequently ulcerative colitis we discovered happen. And if you actually look at this, called a genome-wide association plot or a Manhattan plot, there's a whole host of different genes that are different, what we call polymorphisms, where there's just a spontaneous mutation in the human genome that can be mapped between people with and without disease. And although this NOD2 that was discovered a long time ago as being the Crohn's gene has the highest association, the second highest association is the IL-23 receptor. So this is very strong genetic data to say that IL-23 is important. And so it's not surprising that it was targeted successfully as a therapeutic pathway. So what does IL-23 do? Of course, we never really know what biomolecules do in people, but our best hypothesis is that it supports a couple of types of T cells that may be really important for driving the inflammation of IBD. In the CD4 T cells, these are what are called Th17s. We know that these help cause a lot of pussy inflammatory reactions, but they also seem to drive autoimmunity in a variety of animal models that have really pointed to these as the major target of IL-23 therapy. But there's another type of cell called a mate cell, CD8s, that are interesting because they are really mucosa associated. So they live in the gut. They recognize a vitamin precursor that's made by gut microflora. And so they may also play a central role in the pathogenesis of IBD. Regardless, work from my own lab that I haven't yet published shows that if you look at the peripheral blood of people before and during treatment with this anti-IL-23 called ustekinumab, you can see that both the Th17 and the mate cells do drop off significantly while the people are on therapy. So that does appear to be an effective therapy. So IL-23 looks like this. This is just a model of what the protein looks like in 3D modeling software. It has two subunits, P19 and P40. And P40 is actually not just part of IL-23, it's also part of another cytokine called IL-12. And so Ustekinumab, because it blocks P40, actually blocks both IL-12 and IL-23. So newer agents that are in development that I'm going to be talking about are exclusive to P19. They only block P19. They don't do anything to IL-12. And so they are much more specifically an anti-IL-23 agent. However, it's not really clear that they differ functionally at all from Ustekinumab. But that story is still evolving. So this is just a cartoon of what I'm talking about. That Ustekinumab, because it blocks both the P40 subunit of IL-12 that drives, it actually drives a type of T cell called a Th1, and it will block that as well as the IL-17 from IL-23 that I talked about. But the newer ones, Risankizumab, Mirikizumab, Rizankizumab, Giselkumab, these only block IL-23, so they leave the IL-12 signal alone, and so IL-23 is the only pathway that they block, so the only thing they would be blocking are like Th17s and mate cells. So where are we right now with these anti-IL-23s? Well, they're all kind of in late stage trials that are either actively recruiting or very near completion, with the exception of the Crohn's trial, the Crohn's trial of Risankizumab for phase 3 trials were actually completed and submitted to the FDA for approval last autumn. And so we're expecting this drug may be coming out soon for new treatment therapy, new treatment strategy for Crohn's disease. Whether it's better or worse than Ustekinumab is to be seen. But here's the actual trial data. There were several different trials that went to FDA approval, and this is a composite of their data. The main point is that after 12 weeks, colonoscopic improvement was seen in about 3 times as many people who got Risankizumab than people who got placebo. So that was very statistically significant in this chart. And also when they carried out those people who got better on Risankizumab, they took them all the way out to a year, they found that 47, almost half of the people who got Risankizumab continuously maintained remission, whereas less than a quarter of people who got placebo managed to keep themselves in remission. And so this is the maintenance data down here. Really the bulk of it is this figure over on the left. The left two most columns are what I'm citing. But what's interesting here is that we know that normally once people have tried and failed multiple different biologic drugs, they are less likely to respond to another drug. We don't see, I mean, there's a little bit of that signal here. These are people who previously, these are people who'd previously been on a biologic. These are people who hadn't. And so you can see that there's somewhat of a difference in terms of the response rate, but it's still quite robust. And it doesn't really look like the difference between placebo and response is that badly impacted by having previously tried and not obtained control with a biologic drug. And so this may be a good rescue therapy for people who have previously been on medications that they haven't responded to. Another thing about Risankizumab is that it's reasonably fast. It's not super fast, but you can see that you start to see the purple lines here deviate from the gray placebo line at about 4 weeks. Although I wouldn't declare success or failure with this drug until you're at about 8 to 12 weeks, where you really see a pretty significant separation from placebo by all these different criteria in a couple of different trials. So, having said all that, what does the safety of Risankizumab look like? It's tough to say much about safety from a clinical trial because they're generally not that big. Adverse events are very rare, and they usually take a long time to convince yourself that they will or won't happen. But all we have so far is 65 Crohn's patients who had been on a phase 2 trial for a median of almost 3 years. And what we saw was a pretty low rate of serious infections, about 4% a year. Opportunistic infections, less than half that. Fungal infections, 6.6% a year. And importantly, throughout all of this monitoring, no deaths, cancer, heart attacks, strokes, tuberculosis, or shingles were identified. So the main things that tend to crop up as adverse events in a clinical trial were not really observed in this cohort, and we don't really expect them to be because we now have about 13 years of open label follow-up on people who got ustekinumab for psoriasis, and we're really not seeing much of a safety signal with ustekinumab, which is going to be largely the same mechanism of action as risankizumab. Also importantly, anti-drug antibodies were rare, transient, and unrelated to treatment safety or efficacy in recipients of risankizumab. So much of our concern about developing an immune reaction to your biologic drug that was such a bugaboo of the anti-TNF class has not really been an issue for the anti-IL-23 class. So they may be a more forgiving biologic than the anti-TNFs. This is a different anti-IL-23 called Risankizumab, which is made by Janssen, and so Janssen also, they tried it against their latest anti-TNF. So golimumab and Risankizumab are both Janssen products, and so you had one company that was putting its own products against each other in a head-to-head trial. And so this trial called Vega looked at golimumab alone, Risankizumab alone, or the combination of the two. And what's interesting here is they consistently had better outcomes if people were on two drugs instead of one. And what struck me as particularly fascinating is that for many of these outcomes, they're almost additive, where if you take the percentages and add them together, you get the combination of the two, which tells me that the Venn diagrams between patients who respond to drug A versus drug B are largely not overlapping. So that probably suggests that there are two different types of ulcerative colitis, one of which responds to IL-23 and one of which responds to blockade of TNF-alpha. And so if we can figure out who is who based on their immune systems, I think this is a fascinating opportunity for targeted drug therapy and trying to customize and personalize the treatments for the patients. But as of yet, we have no predictive biomarkers to tell us who's who. So that was the anti-IL-23s. Moving on to the Janus kinase inhibitors, or Jakinibs. These are fast oral medications, but we're going to talk a bit about their safety. So Jakinib itself is just a portmanteau of Janus kinase inhibitor. These are small molecules, so you can take them as a pill. They block an enzyme called a Janus kinase that is used inside the cell to deliver a signal from the receptor on the cell surface into the nucleus to turn on genes and affect the activity of the cell. Although there are many different cytokine receptors, what's interesting is there's only 4 different Janus kinases, and so it allows the pharmaceutical to target a narrow range of proteins that affects a wide range of signaling molecules outside the cell. And so this is how they work. Normally a cytokine's outside the cell here. It brings 2 chains together. Each one has a Janus kinase on it. When they're pulled together, they put phosphates on the receptor. That pulls up signaling molecules that they put phosphate on. Those signaling molecules then move into the nucleus and drive gene expression. But when you have a drug like tofacitinib, which is a Jakinib, it prevents those Janus kinases from putting phosphates on proteins, and consequently the entire signal chain is blocked. Now this is what I'm talking about, how there are lots of different cytokine receptors out there, many different types of cytokines, many different types of receptors, but you can see that there's only 4 different types of Janus kinases on the inside through which they deliver their signals. So when you use a conventional biologic like ustekinumab that blocks one of these types of cytokines, the IL-12/23 receptor, for example, you're just blocking one immune signal that the immune system uses. Hopefully it's a very important one, but it does allow the immune system to sort of figure out how to make inflammation without using that pathway. In contrast, when you use a Janus kinase inhibitor like tofacitinib, you're blocking just about everything with one agent because the molecules are so conserved between the different receptors. These Janus kinases are basically a functional bottleneck that we can use to shut down an immune response. Another cool thing about the Janus kinase inhibitors is that they're very fast. This is a study showing that the people on treatment deviated from the people on placebo by 3 days. There was significant benefit on drug relative to no drug. And so it's clear that this is a medication that rivals prednisone in terms of how quickly it can get people into remission. So it's a good drug to try and get people out of the hospital. Now, the main issue that's come up within the past year about Janus kinase inhibitors is it's pretty clear now they're not as safe as anti-TNFs. Over a year ago, the manufacturer released some post-marketing data that led the FDA last summer to add a black box to the indication. I'll show you in a second, but you can see here that a variety of different adverse events are numerically and statistically more common in people on tofacitinib than one of the anti-TNF biologics. So here it is in chart form and here it is in graphics form. You can see that, for example, serious infection, especially at 10 milligrams twice a day, the higher dose of tofacitinib, You have higher rates of infection, including opportunistic infection, much higher rates of herpes zoster, abnormal liver tests, non-melanoma skin cancer, potentially fatal blood clots to the lungs, although they're rare, less than 2%. It's still way higher in the people on a Janus kinase inhibitor than on an anti-TNF. And other thrombotic events and all-cause mortality was just simply higher in people on tofacitinib. Now, I will qualify that this is mostly a rheumatoid arthritis population, mostly people over 50. Very few events were seen in people under 50, who are a lot of the inflammatory bowel disease population, but nonetheless, this has given the FDA cause to put this black box warning on the medication last summer that there is serious risk of infection, mortality, malignancy, and major adverse cardiovascular events and clots, particularly in older patients on the higher dose of the medication. So just something to keep in mind when considering Janus kinase inhibitors. So that was tofacitinib, which we've actually had for a couple of years now for ulcerative colitis. Where are we with the newer ones? What's interesting is that tofacitinib was not very effective in Crohn's disease, but it was in ulcerative colitis, so that's the only FDA approval we have. However, we now have several Janus kinase inhibitors that showed some clinical efficacy in phase 2 trials in Crohn's disease that are moving forward, or in the case of Crohn's disease, have completed phase 3 trials. And in ulcerative colitis, upadacitinib has not only finished phase 3 trials, it was actually FDA approved for this indication less than 2 months ago. So this is our newest medication for inflammatory bowel disease, is a second-line Janus kinase inhibitor called upadacitinib, now marketed under the name Rinvoq. This is just the clinical data that led to its approval. 2 different trials, both showed significantly better week 8 remission on upadacitinib relative to placebo. Both showed, 2 different doses of upadacitinib, both showed remission at week 52, well above placebo. And so we do have FDA approval. They listed an onset of response as early as week 2, but that's only because week 2 was the first time they looked. There was actually an abstract presented at the European Congress this past winter that shows that you actually see some of the symptomatic improvement scores better than placebo 1 day after starting the medication, and definitely by 2 days almost all of these indices are significantly deviated from placebo. So it really does look like this drug is at least as fast as tofacitinib and an excellent choice to potentially get people out of the hospital. So it's fast, it's potent, and uniquely to this drug, which we did not see with tofacitinib, upadacitinib works in Crohn's disease. So by several different clinical and an endoscopic measure, you can see that upadacitinib outperforms placebo in 2 completely independent studies. And so the manufacturer is presumably going to be submitting for FDA approval for this drug in Crohn's disease in the near future as well, where I think it's really going to make a major difference because we don't have a Janus kinase inhibitor for Crohn's disease yet. Now, having said that, upadacitinib has the same black box warning that tofacitinib does, so this is probably a class effect where all of these different Janus kinase inhibitors are likely to have a higher risk of infection, blood clots, cardiovascular disease than the TNF-alphas. So they may actually be reserved as second-line therapy after TNF-alpha failure, or maybe relegated to just induction therapy rather than keeping people on the drug long-term just for a transient induction because they are so fast. It's not a bad idea to use a drug like this to get people's inflammation under control. So moving on to the last class of drugs about which we know the least, the S1P1 agonists really have no precedent. So what is an S1P1 agonist? It stands for Sphingosine 1-phosphate receptor agonist. That gibberish basically refers to this mechanism that your immune cells use to find their way through a lymph node. So S1P1 receptors, the agonists are small molecules, so you can take them orally, and they activate the S1P1 receptor, which is something that the lymphocytes use to basically smell their way out of a lymph node. Normally there's a concentration gradient of sphingosine 1-phosphate across the lymph node from the exit getting more dilute as it moves towards the entrance. And so as the T cell comes in, it migrates across and it smells that gradient to find its way out, sort of like a salmon smells a gradient to swim back upstream to its original breeding ground. Now, if you stimulate that receptor with the drug, the S1P1 agonist, it basically floods the system. It's like filling the room with perfume. You can't smell a thing because everything, your nose just kind of shuts down. And so as a consequence, the lymphocytes swim into the lymph node and they get trapped because they can't smell their way out. And so that's how this drug is thought to work. So where are we with S1P1 agonists? Well, we have one. Ozanimod was FDA approved less than a year ago. It goes under the trade name of Zeposia. Unfortunately, it didn't show any efficacy in phase 2 studies for Crohn's disease. There are phase 3 trials underway, but the recruitment's been slow, and it's not clear that this drug, or perhaps even this class, will ever make it to market for Crohn's disease. But there is a direct competitor to Zeposia called Etrasimod, which is currently in phase 3 trials for ulcerative colitis. And that data is forthcoming, so there's likely to be some competition in this space for two very similar drugs that target a novel mechanism. We do know that Ozanimod works in ulcerative colitis. This is the data from the clinical trial that led to its FDA approval. And you can see in blue, every single clinical or endoscopic outcome, they looked short-term and long-term, looked better than placebo in gray. So all you need to know is that everything was statistically significant. It outperformed placebo and hence got FDA approval. However, I will point out that this is a very cherry-picked population that was studied in this clinical trial because they capped prior exposure to biologics at 30%. So 70% of these patients who had never used a biologic drug, and that probably, if it's like other drugs that we've trialed, that probably constitutes the bulk of the treatment response that we're looking at here. So whether this drug has comparable efficacy in somebody who's already tried other drugs is still unknown. It could be that this is a good drug for initial therapy, but not a good drug for rescue therapy of somebody who's already been on multiple agents. But time will tell. There will be subgroup analyses of these data. This only came out in September, so stay tuned. We're going to learn more about how this drug works. Another issue is that they cherry-picked the patients in terms of making sure nobody had any cardiovascular risk factors and that everybody was immune to shingles, because those two signals came up with other drugs as being potential complications. I mentioned major adverse cardiac events being associated with the other oral agents, the Janus kinase inhibitors, and they limited the chance that this would happen in this trial by excluding anybody who had pre-existing cardiac disease. And likewise, tried to minimize the rate of shingles by making sure everybody was vaccinated before they started the study. So that is a question as to what's going to really happen once we start using this medication out in the real world for real ulcerative colitis patients who are not so cherry-picked. And a point of concern is that this drug's already been tried in multiple sclerosis, and you can see here that within a month of starting the medication, a particular circulating white blood cell called a lymphocyte drops dramatically. So its concentration drops well below half of its starting point on the higher doses of Ozanimod. So it is typical to see people with what would be an alarming degree of immunosuppression in their peripheral blood that in some contexts would be comparable to what you see with say, an HIV infection, increasing your risk of opportunistic infections. And this was the main adverse event that we saw, was this very low, very common decrease in the lymphocytes. It usually wasn't severe, so they were less than 500 per microliter, but not less than 200. And then some liver test abnormalities. But despite the fact that we saw this very common decrease in lymphocytes, there really wasn't a particularly high rate of infection in either the induction or the maintenance portions of this clinical trial. So it doesn't really look like most of these infections are significantly higher in treatment recipients than placebo recipients. Cardiovascular issues were rare, but they were more common with Ozanimod because it does appear to cause a low pulse called bradycardia, high blood pressure, and sometimes the complications of high blood pressure. So certainly in a population that has pre-existing cardiovascular disease, this drug may require an extra level of caution. So in conclusion, there are new medications for IBD that are coming, largely binned into these three major classes, the IL-23 blockers, which are all either IVs or shots. They're safe and effective. Skyrizi and Guselkumab are already FDA approved for psoriasis and soon to be out there for inflammatory bowel disease. However, these might be mechanistically redundant with Ustekinumab. They seem really similar in terms of safety and efficacy and certainly the mechanism of action. My main hope for these medications is less biomedical than economic. I am hoping that by having more free market competition within this class, we will actually see the cost of Stelara go down because it is currently the most expensive biologic drug for inflammatory bowel disease. The Janus kinase inhibitors are pills. They're fast, effective, convenient, but they're probably somewhat less safe than a biologic. They're more safe than prednisone. So I think what you're paying for is basically a safer version of prednisone. It's fast, it's safe, it's effective, or not as safe as a biologic, but it's faster, and it's way more expensive than prednisone. Upadacitinib is already FDA approved for ulcerative colitis. It's mechanistically redundant with tofacitinib, although it may be more effective in Crohn's disease. So once it gets FDA approval for Crohn's, I think that's where it's going to really make the biggest difference to real-world patients. And then finally, the last class, the S1P1 agonists. It's the newest class, so far not showing any efficacy for Crohn's, but could provide a novel treatment option for patients with ulcerative colitis. There hasn't been much post-marketing data on this, so we don't really have a good real-world sense of how well this class of drug is going to work. And it doesn't have any competition as yet. Zeposia is the only drug in the class, but hopefully Etrasimod will soon come out and give it some competition that will hopefully result in some lower cost as well. In summary, I think my mantra of late with inflammatory bowel disease is that if you don't like your treatment options, wait a minute. Every year we have a longer list of new options to offer our patients, and so it is an exciting time to be a provider in inflammatory bowel disease just because this is such a dynamically improving area. Thank you.
All right, well, thank you and for joining us this evening, and thanks to Dr. Lord for his wonderful in-depth talk. I'm going to talk to you about clinical trials in IBD. Our agenda for tonight's talk is to discuss the types of clinical trials that are available, the steps in the drug development process, how we design clinical trials, what to expect when you think about potentially participating in a trial and when might it be the right option for you, and what are some things to think about when you're considering participation in a trial. And then I'll leave you with some online resources if you want to do your own investigations here and understand more about the process or trials that are available. So starting with the types of clinical trials, the most common clinical trial that we do are called treatment trials. And really the purpose of these is to identify new treatments and to understand both the effectiveness of the treatments, how well they work, and the safety, what side effects they might cause. In fact, all of the new promising therapies that you heard about are in some stage of a treatment clinical trial where we're learning about their effectiveness and safety. And all of the medicines that we use, we had to first study in this way. We also do prevention trials where we take patients who do not have inflammatory bowel disease and see if we can identify patients who are high risk and do something maybe to prevent disease onset, or in those with established IBD to try to prevent disease complications or disease relapse. We have diagnostic studies, so sometimes we try to develop new tests to better understand the disease, maybe tests that are cheaper or more accurate, easier to do, blood tests that could potentially replace imaging studies or colonoscopy. And we have to study how well those work, how accurate those tests are in comparison to the diagnostic modalities we already have. Screening trials find better ways to detect IBD in patients who are at high risk, such as those with a family history. Genetic studies look for genes associated with either inflammatory bowel disease as a whole or potentially some subtypes of inflammatory bowel disease. And the purpose of this really, ideally, is if we can find potential genetic abnormalities associated with the disease, if those cluster in particular immune system pathways, we may be able to study those pathways in a little more depth and identify potential targets for treatment, and then move to a treatment type of clinical trial. But the important thing to know is that clinical trials are essential to our understanding of how to diagnose inflammatory bowel disease, how to treat inflammatory bowel disease, and ultimately someday to prevent or cure these diseases. We can't gather that information without doing these studies. There's really no substitute for being able to do a trial and get the information from that study. So what are the steps of drug development? Well, it starts with preclinical studies. Researchers in a lab study the immune system, how it works in normal people, how it works in those with an immune-mediated disease like inflammatory bowel disease, and try to understand what might be abnormal and how we might be able to fix that. When researchers come upon a compound that they think makes the right changes that would be beneficial in humans, they submit an application that's called an investigational new drug application to the FDA, the Food and Drug Administration, asking for permission to study this in humans. And there's already some oversight at that level about how promising is this drug and how safe might it be before the FDA even allows a company to study it. Then we start with phase 1 clinical trials. Really, the purpose of these trials is to understand whether or not the drug is safe to give in humans. For a drug being developed in inflammatory bowel disease, the phase 1 trial might not actually enroll anyone with inflammatory bowel disease. They may be entirely healthy volunteers. And the purpose of the study is to give the drug and see what happens to the human body. Where does it distribute in the body? What are the drug levels? Is it cleared by the kidneys, by the liver? Are there any obvious signs of toxicity associated with the drug? How long does it take for the drug to clear from the body? These are all the questions that we ask in phase 1 clinical trials. When we get a sense of the dose range and whether or not there are any significant side effects, we then move on to a phase 2 study where we recruit patients with the disease of interest. In this case, for the purposes of our talk, we're talking about drug development and clinical trials in inflammatory bowel disease. The purpose of phase 2 studies really are to find whether or not there's a signal of effectiveness of the drug and what dose might be best. So usually phase 2 studies have a few different doses of the study drug and often a placebo group for comparison, and we'll talk more about that in a bit. Usually these studies have a moderate number of patients, 50 to 200 people. If in the phase 2 study we do see that the drug works better than placebo and is safe to use, then we move on to phase 3 studies. And these are the large pivotal trials that are done just before a drug gets approval. So they need to pass muster in phase 3 in order to get FDA approval. For these studies, we recruit a large number of patients, a few hundred. Some studies have over 1,000 patients in them. And once we know what the best dose to use is from our phase 2 studies, we give that to patients and we see how they do. Generally, trials for inflammatory bowel disease have 2 phases, where we study induction of remission, taking patients with active disease and seeing if we can get the drug to induce remission. And then taking patients who have achieved remission, or at least a response with the drug, and randomizing them to continuing or stopping the drug so that we can learn whether or not we need to continue the drug as maintenance therapy to continue to see benefit. Many of these trials, if you enroll in them, are a year long or so, but may have a long-term extension so you can continue to receive study drug even when the original study is over. If 2 different phase 3 trials show benefit and safety, all of that data is submitted to the FDA, it's reviewed, and the FDA will grant approval to market the drug and for use in inflammatory bowel disease. Sometimes we then do phase 4 clinical trials where we study how well the drug actually works in ongoing use in real-life clinical scenarios out in the real world, not in the highly selected clinical trial population that's closely monitored. So how are trials designed? Well, the design of the specific trial is going to depend on which phase clinical trial it is and what questions the investigators are trying to answer. But all trials are going to have a protocol, which is a long document that details everything about the study, the patient population that you're going to be studying, a timeline for all of the treatments, all of the assessments that will be done to determine the safety and the effectiveness of the drug, and a description of the treatment algorithm, which patients will be assigned to which groups, Will there be blinding or not? And how you're going to do the comparison, the statistical analysis between the groups to be able to understand whether or not the drug works, or to answer the question that the trial is designed to address. There are some common elements that are important to think about, and some vocabulary that I may have already been using in this talk that it's good to review right now. Starting with a control group. So whenever we're trying a treatment, we need to know if it works better or worse, or is safer or less safe than some comparison group. Oftentimes we compare to placebo, which is an inactive compound that otherwise looks identical to the study drug. Sometimes we use an active comparator, so we may compare a new drug to an old drug that's on the market. We may compare a new dose of an existing drug to the standard dose of an existing drug. But we need some comparison to tell if the new thing that we're doing is any better or any worse, or any safer or less safe than what we were doing before, or than doing nothing at all. Randomization is a common element in well-designed clinical trials. And in this, with this technique, patients are randomly assigned to the different treatment groups. The reason to do that is that you want to make sure that both groups are similar with regard to the age, the gender distribution, the number of prior therapies that they may have received, any factors that might be associated with the outcomes of interest. You want to make sure that they're evenly distributed in the groups. We could try to do that in advance by identifying the factors that we think are associated with outcomes, but there may be factors we don't know about that are associated with outcomes, and randomization makes sure that the groups are similar with regard to the things we know about and the things we might not know about that predict outcomes. Blinding is a technique that's used to reduce bias, and with blinding, both the patients in the study and oftentimes the investigators as well do not know what treatment group the patient has been assigned to, whether they're receiving placebo or the study drug, or what dose of study drug they might be receiving. When patients or the investigators are aware of what group they're in, it may affect their interpretation of the symptoms, the scoring of their symptoms, the way they rate their general well-being, the way physicians interpret the colonoscopy findings. So blinding is a technique that's used to reduce bias and gives more accuracy to the results of the study. This is an example diagram that I made up. This is not from any real trial, just to illustrate what protocols look like. So you can see here on the left of the screen, at screening, there are about 125 patients that are anticipated to enroll in this trial. And with this trial, I'm going to say that there's a 3-to-2 randomization, meaning 3 patients will be assigned to the drug group and 2 to the placebo, or 60% are going to receive the drug and 40% placebo off the bat. At 12 weeks, they undergo a colonoscopy, which is the primary outcome, and then get re-randomized. And at this point, it's a 1-to-1 randomization. So those who receive the study drug, half will continue at that high dose and half will drop to a lower dose. Those in placebo, half will get the high dose and half will get the lower dose. And then those patients will be followed through to the end of a year with another colonoscopy. Every study is different, but these are fairly common study designs. With this one, another protocol that I made up, patients who are enrolled are randomized 1-to-1-to-1 into 3 treatment groups, so a 1/3 chance of ending up in each treatment group. At week 16, the primary outcome assessment, patients are classified as responders or non-responders, and what they receive beyond that depends if they responded. Those who responded to whatever group they were on will receive the same thing. And those who didn't respond will receive something different. And that's also a common study design that is used. It's important when you're thinking about participating in a clinical trial to understand what the algorithm is, so you can understand what are your odds of receiving treatment, at what time point will you undergo an assessment like a colonoscopy, how long does the study last. So let's talk in more detail about the process for clinical trial participation. It starts with identifying a study, then informed consent, the screening period, enrollment, and then of course at some point you will withdraw from the study when the study ends or earlier if you choose to. So how can you identify trials that are right for you? Well, first, talk to your provider. The goal is not to find a treatment to take. The goal is to optimize your health outcomes. So talk to your doctor about the treatment options that are available for you and whether or not a clinical trial might be right. You can search the Crohn's and Colitis Foundation or clinicaltrials.gov if you're interested in promising therapies that are out there. But in general, I would say if you're doing well on your treatment, you should probably stick with it. If you're not doing well, then talk to your provider. Either you're not doing well because it's not working or you're having some side effects. Talk about other treatment options. There may be other standard care treatment options, other drugs that are already approved. In some situations, a clinical trial might be the right option for you. If you decide you are interested in pursuing a clinical trial, the first step is informed consent. And this is a very important part of the process. So with informed consent, you're going to receive a written document that describes everything about the study, the purpose of the study, why we're doing it, the known risks and benefits of the intervention, of participating, your rights and responsibilities as a patient, as a research subject in the study. You have time to think about this. You can discuss with friends and family, with your other providers. You can ask questions. There's no rush to sign this. There's no arbitrary deadline about when you need to return the documents. And when you're ready, you have a conversation with a research coordinator to walk through the document, make sure you've read it all, make sure you understand it all, see if you have any questions, and if you want to move forward, then you sign the informed consent document. There are some things that you should probably think about when you're considering participation. What are the risks and benefits to me as an individual? Is this right for me? Is there a placebo group in this study, and what are my odds of receiving placebo? If I do get placebo, will I eventually have an opportunity to get the study drug? Maybe that's right for me if I don't have other good options and I potentially receiving a placebo for 12 weeks and then I know I can get access to the study drug. It might be the right option for you, it might not. How long does the trial last? There's a significant time commitment for participation. And you need to think about whether or not you can commit to all of the study visits. And what's the timeline for treatments and potential financial costs and other treatment options that are available. If you sign the informed consent document, then you enter the screening phase of the trial. And to participate in a trial, you have to meet all of the eligibility criteria, and they're quite numerous for many studies. So we review your medical history and see if you have any conditions that would make it unsafe for you to participate potentially. You'll undergo a series of blood tests, maybe other tests like EKGs or chest x-rays. Part of this is to find if there are any undiagnosed conditions already existing that that if we find out about later in the study, we knew they were pre-existing. Some of those may make it unsafe for you to participate depending on the treatment trial that you're considering. Most IBD trials are going to involve a colonoscopy as part of the screening evaluation to confirm that the symptoms you're having are due to active inflammation, so be prepared for that. Some examples of inclusion and exclusion criteria. So if this is a study of Crohn's disease, it's common to have a inclusion criteria that require a diagnosis of Crohn's disease for at least 3 months. So you may have to have tried at least one approved therapy before considering the trial. This may be a trial that's only for adult patients and no vulnerable populations, so you may have to be capable of providing informed consent yourself, and have to have moderate to severely active disease based on symptoms and colonoscopy. Examples of common exclusion criteria: pregnancy. In general, most studies do not allow pregnancy during the trial. And if that is on your radar during the timeline of the trial, it's probably not a good option for you. You may have pre-existing health conditions or infections that may make it unsafe to participate. And all of those will be tests done in the screening. If you meet all the inclusion and exclusion eligibility criteria, then you enroll in the study. and you'll be likely randomized to one of the treatment groups. You'll begin to receive the treatments of the study and undergo the assessments. So you'll have visits at certain specific times, and at each visit, the protocol is going to dictate what happens. At most visits, we'll get vital signs, take a medical history, do an exam, do some blood work. At some of the visits, you may need additional tests like a colonoscopy, which is often done after induction and at the end of maintenance. You should expect frequent visits, more frequent than you typically see your doctor. It may be every 4 weeks or so for a year or potentially longer. And the visits are going to take longer because the process is designed for safety. So we're very thorough about asking every symptom from a tickle on your scalp all the way down to an ingrown toenail and everything in between. Between visits, you may have a little electronic diary. So you may be asked to put your symptoms into a diary, number of bowel movements, rate your abdominal pain, general well-being, other symptoms. And you may have to do that on a daily basis throughout the trial. Any medical care you receive outside the trial, so if you follow up with your primary care doctor for management of your diabetes or high blood pressure, all of that needs to be communicated to the study team because we need to know everything that's going on so that we can report any potential adverse events or new things that are going on. Withdrawal and termination, of course, once the study's over, the study's over. So if you've completed all the time points, all the visits, then you're disenrolled from the study. Some studies are for a year, but if the drug looks promising, they may allow you to enroll in an open label extension trial where you can continue to receive the study drug. But that's a separate trial that has a new informed consent. You can choose to withdraw from a study at any time for any reason without any consequence. So if you just are tired of all the frequency of visits, you can withdraw. If you are having new symptoms, your concern might be due to the study intervention, you can withdraw for any reason at any time. And the study sponsor and investigator can also withdraw you. If the sponsor learns about safety concerns with the drug, they may close that program and shut down the study. There's oftentimes a safety monitoring board that also reviews the data and may shut down the study. If your investigator thinks it's no longer in your best interest or unsafe for you based on lab works or symptoms or something, they also can choose to withdraw you from the study. You should know that safety is the number one priority. It's really baked into clinical trials from the get-go. Before starting these studies, the study protocol has to be reviewed by the FDA, and then it has to be reviewed by the ethics board at each local site. Many of these trials are international. They may have 200 sites across the world. And each site has an ethics board that has to review the protocol and make sure that it is something that is reasonable to proceed with. Before we're selected as a site for a clinical trial, we have to have a visit to make sure that we have the equipment, we have the facilities to take care of patients, and all of our staff need to go through research ethics training. We need to be trained on this specific protocol. We need the knowledge, training, and expertise to be able to take care of patients. So before we can even enroll our first patient, there's layers of oversight, making sure that this is a study that is safe and ethical and that it can be carried out in the best interest of the patients at each local site. And during the study, there's also layers of oversight. So you're going to have frequent visits with the investigators of the study, the providers taking care of you during the study, with the study coordinators. The local ethics board has to get reports regularly on the outcomes, and they do their own audits of us. A clinical research organization is an organization that conducts clinical trials. So the sponsor, the drug company, may contract with some other company, a clinical research organization, to carry it out. They have monitors that they send out periodically, and they go through all of our data with a fine-tooth comb to make sure that we're doing things correctly, dotting our I's, crossing our T's. The sponsor then reviews all of that data. So there's another layer of monitoring, and they have statisticians, physicians, study doctors who review all of this. Then there's an independent data safety monitoring board that gets aggregate reports to see if there are any alarming safety signals during the conduct of the study that might make it unsafe or unethical to proceed. Sometimes they find that the drug is not working halfway through a trial, and not that it's unsafe, but just that it's ineffective and then unethical to continue. So you should know that this process is very safe. So what are main advantages and disadvantages of participating? I think the main advantage is that you may get early access to promising treatments. If you've tried all the treatments that are available, and surgery may or may not be an option for you, you may be able to get access to some of the drugs that Dr. Lord talked to you about that seem really promising. Another potential advantage is that all the study-related treatments and assessments are typically provided at no cost to study participants. So you don't have to deal with the insurance, co-pays and whatnot. So you can receive treatments and care without additional costs. The main disadvantage, I know everyone worries about safety and not wanting to be a guinea pig, but safety is not really a concern. The main disadvantage is that it's a time commitment, partly because the process is designed for safety. You will have frequent visits, and those visits will take longer, and so you need to make sure that you have the time to do it. You have the child care or time off work or whatever arrangements need to be made. There is a potential for placebo in some trials. Not all trials have placebo, but if so, you need to consider whether or not that is something you could do. Generally, during the placebo phase of trials, we are allowed to bridge patients with steroids so that you can have some relief of symptoms. These are trials because we don't really know the full safety or the full effectiveness of the therapies that we're studying, so there are some unknowns, and that's a potential downside as well. Then there are family planning implications. In general, female patients of childbearing potential should be on an effective birth control during the study, and if you do become pregnant during the study, you're then withdrawn from the study for most trials. Some trials also require for male partners that they use some form of birth control or not try to conceive a child during the study. And these are some resources that you can look at to get you more information about clinical trials in general and what you might need to know when considering participating. All right, that's it. Thank you for your time and attention.